Hello, and welcome to our webinar titled Developing Telemedicine Partnerships for Rural Healthcare. I am Carrie Dostey, Director of Marketing here at AMD Global Telemedicine, and I will be moderating today's webinar presentation. But before we begin, just want to go through a few things regarding questions. All attendees will be on mute during the webinar. However, we welcome any questions that you might have along the way. So if you have questions, you'll see a control in the control panel on the right-hand side. You can type in your questions there. And then at the end of the webinar, we'll go through as many as we have time for. So today's featured presenters are Ron Emerson and Morgan Waller. They're both here today to share their experiences and their knowledge on how to develop successful telemedicine partnerships that will help you extend your service offerings and increase access to care for your rural patients. Ron Emerson is the Global Director of Strategic and Partner Development at AMD Global Telemedicine, and Morgan Waller is the Director of Telemedicine at Children's Mercy, Kansas City. So our goal today is to strive to cover the following topics to help you get started. And then at the end of the presentation, I will share with you each of the presenters' contact details so you can also use them as a resource moving forward. So today we're going to cover how to fill gaps in your healthcare services with highly specialized clinical telemedicine, how to partner with academic medical centers to leverage their services and extend your ability to treat more patients, 3 key things to consider when developing your telemedicine program, and effective practice models and workflows for optimal care delivery, and finally, telemedicine business models that make the most sense for rural healthcare providers. So that we can get a feel for who is listening to our presentation today and what the types of needs you might have, we have a quick poll question for you. You'll see it pop up on your screen, and if you could, I'll give it a few minutes. If you could please select one of the answers. So the question is, do you currently have a telemedicine program? So either yes, you do, and you're looking for ways to expand it or improve it. No, but you're trying to implement one. Or are you just doing some research and you have no immediate plans right now for telemedicine? If you could please select one of those. I'll close the poll in a minute. Looks like people are still, okay. Looks like they're done. And I'll post the results here. So 68% of you do have a telemedicine program and looking for ways to improve it. So congratulations, and that's great news to hear. There's a few of you, 15%, that don't have a program, but you're trying to implement one, and then 18% are currently just doing your research at this time. So our first presenter up is Ron Emerson, and he is going to discuss the 3 key things to consider when developing your telemedicine program. I'll hand it over to you, Ron.
All right, thank you very much, Carrie, and I'd like to thank everyone for joining us today. Just a little bit of my background. So Ron Emerson, I'm the Global Director of Strategic and Partner Development at AMD Global Telemedicine. Prior to joining AMD, I used to run a telehealth network up in the northeastern United States. And then I had a unique opportunity to work with a couple different organizations where I have been able to travel to 46 countries in about 5 years developing telemedicine programs, of course, including a lot of that in the United States. I was on the board of the American Telemedicine Association and have been involved in a variety of roles from not just a technology perspective, but also from a clinical and regulatory and policy perspective as well. So, one of the reasons I came up with this topic was, regardless of where I traveled, I always realized that there's always 3 key things that organizations and sort of proof points that you have to provide and things that you should have in line when developing a new telemedicine program or add in a specialty service or another clinical service onto your program. And we have to validate these things because somewhere along the line, it seems like we're always challenged. And what are they? I think the first thing is we're all in healthcare because, you know, we got into it. I have a bachelor's degree in nursing. You know, we want to ensure that patients are happy and that we're providing a good experience for patients. So we want to be able to show that we can provide good patient satisfaction and a good experience through telehealth, but also provide a good experience for clinicians. The second thing that we want to be able to prove and that we'll be challenged on a lot of times and to be able to validate is clinical efficacy. When you use the definition of telemedicine, it's the transfer of electronic medical data, and that can mean a lot of different things, as all of us know. It can mean direct to consumer, it can mean diagnostic telemedicine with medical devices, and depending on what the actual intent is, we want to try to provide from a distance the same level of care as we would in person when possible, especially with diagnostic telemedicine, right? And we want to be able to show that, and we're going to talk a little bit more. The third thing, and regardless if you're in a private or a public sector or a part of an accountable care organization, or if you're moving more towards quality-based care, we have to show the cost effectiveness and the ROI of why we're doing telemedicine. So these are three key themes that you will continuously see, and along the way, you'll have to talk to the medical director and the people who are concerned about, of course, all of us, the patients, which we all are, the clinicians, to make sure they can provide good quality care, and then, of course, we have to make the financial business case of why. Digging a little deeper into this, and I'm just going to really skim on the surface of this. Patient satisfaction, we have been doing this for years and years and years and actually finding out of patients like telemedicine. Studies go back, I've been involved in telehealth for over 20 years, and most studies show that patient satisfaction rates are above or greater, high than 90% when using telemedicine. So patients like, and a lot of people, some of the studies show that the rates are as high as 96, 97%. They actually love telemedicine. So patient satisfaction has not been an issue. Clinician satisfaction rates are a little bit lower, but they're still satisfactory and they're above 86th percentile. And the only caveat I would add to this is when you're developing your program is would be expected, you know, make sure that you're using the right technology, you're integrating the technology into the workflow so that it's easy for the clinicians and it's easy for patients to experience the telehealth encounter. Kind of a saying I have is if you don't need a Porsche, don't buy a Porsche. But if you don't need a Volkswagen and a Volkswagen won't get the job done, then don't use a Volkswagen, right? Use the right technology to fit that specific application. The next thing I want to talk about, which is a big one, is clinical efficacy. So what quality can we provide of care can we provide over telemedicine? If you look at a lot of the research and the data, we have mostly comparison studies, and a lot of the data really focuses more on telemental health, neurology, and we'll talk a little bit about that, and the other one is dermatology. Just to cite one, some of the better studies out there, telestroke is quite big. University of San Diego did a really good study where they showed the traditional model of someone shows up to the emergency room, they're having a stroke, the vascular neurologist is on the phone, they're looking at the CAT scan, and the emergency room physician is basically providing the information. When the stroke doctor can actually provide the clinical assessment themselves and use the NIH stroke scale, there were significantly better outcomes than just by doing it by the phone itself. Comparison studies have shown that diagnosis, so a lot of studies with mental health and dermatology and others, a lot of them are more comparison studies. So an example of that is what we see quite frequently is where a psychiatrist would go into a room, they would see a patient in person, they would make a diagnosis, that psychiatrist would leave the room, another psychiatrist would come in over video, and they would do the same assessment and they would basically make the same diagnosis. So there was no variance in the diagnosis regardless if the patient was seen by the psychiatrist in person, by both of the doctors, or one over video, or one in person. And of course, the last thing is looking at cost effectiveness. So how do we increase revenue? This is one of the biggest questions that a lot of organizations struggle with. I think it's pretty well been proven when we look at patient satisfaction, we have that. We know patients like telemedicine. clinical efficacy. We have quite a bit of data in certain areas, other areas we're still working, but every organization is different depending if you're an ACO, if you're trying to use telemedicine to increase market share. So there's really kind of two buckets I put it into that help simplify this through your thought process, is how do we increase revenue and market share by utilizing telehealth in a private market, and then how do we decrease cost? Now, there's not a lot of studies out there, as you can imagine, that actually show most organizations that are using telemedicine to increase market share and capture more patients, you know, they're not going to broadcast that too much to the world, right? But one that there is actually UC Davis did a study where they actually showed that they increased revenue from 2.4 million to about 4 million per year. It was a smaller study, but what it was is, in general, is if you're using telemedicine to reach out and develop a relationship with a non-affiliated organization, and your competitor up the road is not, when that patient needs inpatient services, they're going to come to your facility, which is where they're going to receive their ancillary services, MRIs, CAT scans, lab draws, and inpatient services, which is where, on average, 60 to 80% of revenue for most hospital systems comes from. So it really is a way to reach out and develop relationships with patients so they come to you and not your competitor up the street, and looking at it from a pure market share and revenue and the why of telehealth. The other way that we can look at it is how can organizations use telehealth to decrease cost? And we're seeing more of this through capitated rates, right? We get a lump set of money to take care of a patient per month, accountable care organizations. So we have a lot more flexibility of how we choose to take care of patients, and we can actually decrease costs and do things more efficiently through different delivery models through telehealth. One example of that is the state of Texas. This is a huge capitated program, which is called their Department of Corrections, which the University of Texas Medical Branch was given a large sum of money to take care of the entire state's population of prisoners. And they basically have shown that they've saved $1 billion by using telehealth and their electronic health record over the course of the program, which is actually increased now. When you look at capitated rates again, and you look at when we look at accountable care and reducing unnecessary hospitalizations, we can reduce costs by reducing unnecessary hospitalizations. A patient's discharged into their rural community, they can go to a local clinic, or maybe they can even receive care in their home, where we reduce the unnecessary rehospitalization so we don't get the penalties. And this is population health and populated. And then, of course, we can, at a very minimum rate, increase efficiencies. I think all of us can relate to a lot of our specialists getting in a car and driving 2 hours to a smaller clinic, doing a clinic for 2 or 3 hours, and then driving back 2 or 3 hours, which I live in Maine, and that happens quite frequently. And we can only imagine the amount of money we're paying if the physician's salaried. You know, we're still paying those fees without driving any revenue to the organization. So as we look at a little bit more deeper into this and get a little more concrete, ROI and revenue drivers for telehealth, so I broke it into rural. So when you're a rural facility, the way you want to look at this is basically first of all, is from a brand perspective, and of course we're all in healthcare to do the right things for our patients. So we want to increase access to specialty services for our patients that they otherwise wouldn't get. That's the first thing, right? The second thing we want to do is of course, you know, this is a real driver. We can improve our image and our brand of how you're increasing access to services that they otherwise wouldn't have available. And one thing I would recommend, is I've done consulting with many organizations, and this is where a lot falls short, is ensure that you market your program. Market your program and let the community know that this is available. The next thing that's big about this from a ROI revenue driver for yours is you don't automatically lose the patient to the larger facility, which I think we all see very common. And then you can provide those labs, you can provide the ancillary services, they use your pharmacy, and all of the other things that's in the last point there. Now, what's the driver for the Center of Excellence? Why do we see larger organizations utilizing telehealth? And I actually covered some of this before. The first thing, as I said earlier, is increased market share through relationships with patients and rural providers. And that could be non-affiliated organizations, or it could just be to do things more efficient to the organizations that they actually own or are part of, right? And then the last point is patients come to their facility for the inpatient ancillary services, and I'm just sort of repeating what I said before, but it's a key point to help drive increased revenue across the board. And at that point, I'm going to actually hand it over to Morgan Waller to finish the presentation. So thank you, Morgan.
Thanks, Ron. Hi, everyone. Good afternoon. I am honored to be co-presenting here with Ron. My professional background includes experience in pediatric critical care nursing, information systems, and I am passionately curious about just everything. So 6 years ago, under exceptional leadership of Dr. Laura Fitzmaurice, a part-time hospitalist and I started the telemedicine program at Children's Mercy in Kansas City. We had one patient that first year, and now we have 27 specialties that are offering telemedicine services to 4 regional outreach centers. So it's been quite an experience. Carrie.
Should just, yeah,
There we go. Sorry, I couldn't advance the slides, but we got that fixed. So how do you fill gaps in your healthcare services? You can recruit and hire, as you all know, and sometimes that involves recruiting and interviewing, and then you might hire someone and 6 months later they leave. It's a really arduous process. You can refer patients out of town if you're the smaller facility. You can refer them out of town, out of county, out of state, or you can contract for virtual expertise. And contracting for virtual expertise offers your organization the ability to support your providers so they're able to deliver better care themselves to the patients locally. Patients tend to view an organization that brings in expertise more favorably. They don't see it as a weakness. They see it as doing the right thing. Contracting for virtual expertise also allows your local providers to have access to academic resources they might not otherwise have. A lot of larger facilities, when they partner with a rural facility or an access location, will allow those providers to join them in their presentations, their grand rounds. So there can be a professional collaboration established. It allows you to keep, as Ron said, your patients in your facility, which is essentially their medical home. And it can make both the patients and providers in your community very happy. These are just a few of the benefits, really, of a telemedicine partnership. So, oops. This is just because. And, you know, webinars are not the most interactive, obviously, of platforms. So I'll be more than happy to accept smiley faces. You can IM me, happy faces. I think this is the funniest slide I've ever seen in my life. When I came across it, I was laughing out loud in my office by myself. So with that said, I talk a whole lot slower than Ron, and even when I'm fully caffeinated, I don't talk as fast as Ron. So bear with me on that one. We'll try to get through this. I think PowerPoints and webinars can be painfully boring, and I don't want to do that to any of you. So Carrie's allowed us to offer, guys can offer input along the way, and then we'll have questions at the end, and I encourage you to do so. And please enjoy yourself. So before we get into the nuts and bolts of establishing a partnership, where are we in telemedicine today? So there's 15 million Americans received some sort of medical care virtually last year, according to the ATA. And the expectations are that that is going to grow by at least 30%. Depending on what resource you look at, I've seen estimates as high as 49%. And Kaiser Permanente conducted 52% of its visits virtually in 2017. So there have to be cynics, I guess, to balance the dreamers. Less than 2 years ago, I had a provider tell me that telemedicine, this thing is a fad. As soon as insurance companies get wind that it's just double dipping, all this talk will be just wasted time. Well, I'm not so sure that that's actually going to be the case. The polls show that 94% of virtual visits resolve the reason for visit. So it's not double dipping. In the beginning, a lot of insurers, payers were very concerned that that is what it would happen, that you would have a telemedicine encounter and then the next day you would go in and see the doctor or go to urgent care anyway. Well, that's not what happens. I would be interested to know exactly what the resolution rates are for traditional in-person visits. I would guess that they're not 100% either. So at any rate, virtual visits resolve the reason for visit, and 72% of people will try it. So, you know, 3/4, in addition to the fact that if you ask people if they would rather have access or be with their physician in person, contrary to what a lot of providers think, patients actually would rather have easy access. So 3/4 of patients are going to be doing this if they're not already. So it's not a fad. So there's regulatory changes that are going on in telemedicine today, somewhere, all the time. It's almost impossible to stay up on everything because each state, in addition to at the federal level, have their own legislative actions that determine how telemedicine can be practiced. And certainly you could have a whole series of webinars going over the laws regarding the practice of telemedicine. So just basically the federal level, there's regulatory changes going on, and at the state level, the good news is in at least 48 states, the telemedicine legislative changes are for broadening, expanding telemedicine, increasing the reimbursement rates, getting rid of some of the arbitrary restrictions that have been there in the past. I would say Missouri has one of the most impressive telemedicine laws right now on the books. They have basically said in 2 short paragraphs that as long as a licensed provider in Missouri meets the standard of care, it doesn't matter where the patient's located, and they've got rid of all of the additional restrictions. The thing that determines whether or not telemedicine can be reimbursed is if the standard of care is met. So hallelujah, it's amazing and simple. Again, hospitals, 72% have some sort of a program. Physician groups now, at least half of them have some sort of a telemedicine program. The way you guys answered the polls yourselves for this webinar indicates that people have telemedicine programs. And they're also, large insurers and large companies are offering telemedicine benefits for their employees. There's many different varieties of telemedicine. That could also be another week-long series of webinars, but the tele-ICU model, where the smaller intensive care units across the nation are being supported by remote intensivists and experienced ICU nurses, this is just a win for everyone. Being a PICU critical care nurse myself, had I not burnt myself out completely when I was younger and moved on to a couple of different careers since, I would have really valued the option of doing patient care virtually, using the expertise of many years in critical care, being able to support a newer nurse remotely when you're physically and emotionally exhausted. That's a great way to flex your retirement or your exit strategy, if you will. Same way for providers too. Not that it has to be that way, because there are a lot of young providers who think that really are drawn to the technology and like to support the virtual tele-ICU as well. And then you can take advantage of the biomedical device interfaces and data analytics to identify trends that a smaller ICU would not have the capacity to do. This slide just demonstrates the variety of methods, your direct-to-consumer, the development of devices that you can buy over the counter to aid a direct-to-consumer experience. I really see in the future that much like inhalers are prescribed along with your asthma medications, I think in the future a child with chronic ear infections could receive a prescription to purchase an an over-the-counter device that allows the family to look inside the ear and send that display through Bluetooth to a direct-to-consumer provider. And I think the insurance companies will pay for that. The savings in having to go into a facility each time your child has an ear infection could be huge. People are, can see their, like in Missouri, you can see your physician anywhere, on a train, on a boat, in a car. So as long as the standard of care is met. A lot of long-term care facilities, assisted living centers, rehabilitation centers have incorporated telemedicine, allowing providers and family members to join, because you can do a multi-point experience. So if your parent is in an assisted care living center and you want to participate in the encounter as a family member, you can do that as well. That increases the communication among all those involved. No one has to travel. The person that's at the facility doesn't have to go to a local healthcare facility via EMS. It's a win-win. So you get it. I don't want to belabor this too much. You understand. Telemedicine's real. It's here. It's not a fad. So what are we going to do? I think what we're going to do is we're going to take another question. Carrie?
Yes, thank you, Morgan. Before we continue, we do have another short poll question for the audience so we can gauge the type of specialties you need most. So I'm going to go ahead and share just give me a second, share the next poll question. Okay. So what are the most unmet needs of the patients you serve? So there are many options that we realize for specialties. We just kind of kept the top 5 or so specialties that seem to be the most common. So if you want to go ahead and select which one or more of the following, one of the following is the most unmet need: behavioral health, neurology, allergy and asthma and immunology, oncology, or cardiology. And I'll give you a few minutes to finish putting in your answers. Okay. People are still answering. Hold on. Okay, I'm going to go ahead and close the poll and share the results with you. 68% of you said behavioral health, 26% said neurology, 23% said allergy, asthma, and immunology, 19% said cardiology, oncology, and 27% said cardiology. So behavioral health is definitely one of the largest areas that we see the need for unmet needs, and it is also one of the easiest types of specialties to implement with telemedicine, because there is, less technology involved or less equipment. It's a good way a lot of programs start. So I'm going to go ahead and move on to the next slide for you, Morgan. Go ahead.
All right, thank you, Carrie. So yes, behavioral health. Everyone needs additional support in behavioral health. That is for sure. So how do you partner with an academic medical center? If you're the rural site or the access site, or you want to identify, just as the poll that Carrie presented you with, the unmet needs of the patients you serve. So before you make the phone call or the trip to the city, these are the things that you want to identify and answer, so you're prepared, because all the providers of the expertise are going to want to know the answers to these questions. So from each unmet need that you identify, how many patients are going without or receiving low quality care? So what is the volume of patients from each unmet need or each unmet area that you serve, that you want to get expertise for? And then, are you sure that your organization's administration is completely and totally in? A lot of times you may hear that they are, and then find out after you've gone out and tried to form a partnership that, oh no, that's really not what we meant. We didn't. I know that I have done that more than once. I have taken the lead and gone out to do what I thought was the right thing, and then found out that, oh, we were just kind of talking about that. We didn't really mean it. So make sure the communication is very clear. And then what about the staff? You have to have the buy-in from the staff that will be supporting these programs. Do you have nurses that would be excited about facilitating encounters, or would they see it as a burden? They don't like technology. That can make your program fail if the providers, the facilitators, are not excited about it. It just makes the program look bad, and then telemedicine's blamed, and that's really not the reason. Do you have technologists that are game for getting specialized training? So if you are an access hospital and you want to partner with a larger organization, say for your pediatric radiology or some sort of special radiology, well, that radiology tech that you have on site may feel perfectly comfortable taking x-rays on a child, but it may not be exactly how the academic medical center thinks they should be done. And that can be an uncomfortable situation. So you want to, when you're making your partnerships, you want to partner with an organization that is really good at empowering the local caregivers, technologists, providers, without making them feel like, and I think Ron mentioned this, that Big Brother is, there to take over. This is a partnership, and everyone has something to offer, but it's really important that you, again, communicate that there could be some training involved and some new ways of doing things. And then, do you have someone in your organization that can be the program coordinator? You may be the one passionate about this, you may be bringing it to the table, but someone's going to have to own it and operationalize it, and it has to be easy for the providers. One of the quickest ways for a telemedicine program to fail is if you expect the providers to be the ones to do it and the nurses to just do it. They already have enough going on. You have to have some champions, and you have to have someone that has the time to make this their job. And then, do you have the facility to support this, where the patients can go and have an exam in a private, well-lit space with the technology that you've agreed upon is necessary? Like, is it the Porsche or is it a Volkswagen? And the internet service, that has to be the Porsche. You really can't, you can't go the Volkswagen route on your internet connection. So you need to have some good resources. If it's Wi-Fi, you have to have great access points, and it's better to go, if you're a rural area, with a hardwired connection. So another part of your organization that will need some assessment is, what about your contract person, your business development team? Have they heard of telemedicine, some of the different business models around telemedicine? Does the credentials committee at your organization know what telemedicine credentialing by proxy is? That is a term, it's not exactly credentialing by proxy, but that is what it's been, that's just what people refer to it. It's where the smaller site relies on the larger organization's med staff processes, so they don't have to go out and credential from scratch each one of the providers that are going to be offering telemedicine to their patients. It makes it a much faster process, but it does have some nuances, and it's important that the staff at the access site know what those nuances are, because there's a lot of times there'll be a couple of changes that have to be made at the access site's medical staff bylaws. And then there'll be ongoing professional practice evaluations that will have to be filled out annually on the providers that are seeing patients in that rural access site. Is the billing team at your organization familiar with telemedicine facility fee charges, CPT codes that can be billed for telemedicine, ones that can't? Those types of restrictions will be important as you try to recuperate some revenue on your program. And then, do you have a way to exchange medical records through a health information exchange or some sort of secure electronic file transfer? In an ideal world, you'd share the same EMR system, but as we all know, there are several different vendors out there and they don't all speak to each other. So there must be a way that you can establish that communication of electronic health records between organizations. So the telemedicine models, this is certainly not an exhaustive list, but one I've been speaking of most is that Access Hospital and the larger academic medical center. But there's also EMS teams that partner with academic medical centers, so there can be providers virtually in the ambulance or in a mass casualty situation, like with the hurricanes most recently, they have providers that are there virtually on site with the EMS team. There's the facility to facility to facility model, which is that's the model that we use at Children's Mercy in Kansas City because we own our regional outreach centers. So we're the hub and the spoke, which that terminology is kind of old and a little cliche, I think, but it's still used. So we're the main supplier of the expertise, and then we own the regional outreach centers where the nurse telefacilitators are located, and it allows patients to come from lots of different areas, saves their travel a great deal, but not completely. And then there's home, so you can have a specialist and now be seen in the home in a lot of states and a lot of places. And then before long, like as I'm in the state of Missouri, patient anywhere, provider anywhere. It's not really going to matter as technology continues to improve. Video and our internet and Wi-Fi, 5G, when that arrives everywhere, that'll be a game changer. So there's a lot of different ways that you can look at your telemedicine program, how to offer the services, where to offer the services, and what you might be thinking about in the future. So essentially, in the telemedicine world, under care delivery, there's asynchronous telemedicine and synchronous real-time. So asynchronous are your store and forward. Like I said, if you want to partner with a larger organization for your radiology reads, that's when a test, any type of diagnostic test is done and then transmitted for interpretation later, and the reports sent back on a predetermined, pre-agreed upon amount of time, like within 24 hours, or if it's stat or urgent, within 12 hours. Obviously, your email, electronic communication, and web-based management. Then synchronous is that real-time piece where you have medical visits on demand. You could have remote monitoring, the tele-ICU pictures that we looked at, transport where the provider's in the ambulance along with the transport team, virtually along with the transport team, and then your remote virtual patients where you're seeing them at another facility but in real time. And then there's the facilitated versus non-facilitated. So that's when you need, based on the available diagnostic exam devices and the type of provider and type of exam that's needed, you may or may not need a trained person to be with the patient. So it could be an RN that spends time with the provider and then lives in that access site, lives at that access site, or works in your organization and has spent time at the academic medical center getting trained. And then they can facilitate some pretty specialized exams, which allows level 3 and 4 billing. As long as that standard of care is met, a facilitated encounter can replicate the quality of an in-person visit. And then the non-facilitated direct-to-consumer, the stuff that we're now seeing. seeing advertised pretty much everywhere on television anymore. That was my cat, I'm sorry. Okay, so contracts. You will want to have your business development team, like I said, kind of up to speed on the telemedicine stuff. And I have experience with basically two types, where the distant provider site bills provider fees and the near patient site bills the facility fees. A lot of times there'll be two account, or the patient will become a patient of the larger center as well as that local center. So there'll be medical record numbers at both places, or you can have a contract with the reassignment of billing rights. In that situation, you could have a monthly invoice for the call time of the specialist, or a monthly invoice for the actual time that the specialist spends with the patients, or a combination of both. Ron mentioned a little bit earlier about the telestroke programs, and this, I usually try to include a blip about this whenever I present about anything because of the ethics involved in telestroke, and because this is a webinar about developing telemedicine partnerships for rural healthcare. Telestroke programs are changing people's lives. They're changing stroke victims' lives, and they're changing their families' lives. Not only is it a cost saver for families and our healthcare system at large, the outcomes are, with every minute that you decrease the time at which TPA is delivered, you increase the outcome of the patient. So there's a real benefit. It's much like in neonatology. For every hour that you increase gestation, you increase the outcome of the child and decrease the cost of a premature baby in a NICU. So these are things where telemedicine can make a huge financial impact and a ethical impact because of the way families are affected. And a quality adjusted life year is a kind of a complicated way of saying that if you save someone's life by a telestroke program and they live 10 years, what is the quality of life going to be for them, and how much is that going to cost? And how did the telestroke, and based on their sequelae after the event, what will it cost to basically support them? And telestroke programs cost less than $2,500 a year for a quality adjusted life year, which in the past, anything that could be done to decrease that quality adjusted life year to less than $50,000 was considered worth the investment. So our telemedicine program at Children's Mercy in Kansas City has access to what I call super specialists, because they're all pediatricians, so they're specialists anyway, and then there's board certified and spend fellowship programs in additional specialties. And we have 11 of the 14 ABP subspecialties providing telemedicine, 4 of the 5 ABP co-sponsored subspecialties, and then a little low, I think we have 29 now, but 27 specialties and subspecialties combined that are offering telemedicine in some capacity. And that picture of me, that picture could be of me when I was a kid, because I grew up in Southeast Kansas, and that's what it looked like. There were actually places that didn't have telephone poles. And it's hard to get a specialist when you live in a situation like that. This is a list of our specialties. So just to give you an example, when you're running through your mind of what the needs are of the patients that you serve, you really can get an expertise, a virtual expertise in your center for pretty much anything anymore. Here are a few quotes from our patients and families, speaking again to the well-established fact that people love telemedicine. It is highly satisfying. Thank you so much for working with me and providing this service. I wish we'd done this 3 years ago. It was a great experience. It was amazing. I've heard people say that they like to be able to see inside their kids' ears, which they can't normally do in the office because of the way the digital ophthalmoscope, or otoscope, excuse me, shows the picture back to the family. So to sum up, I want to make sure that we covered what we said we would cover, and if not, we can address it in questions, or if we need to further elaborate on a topic. We were supposed to talk about how to fill gaps in your healthcare services with highly specialized clinical telemedicine, how to partner with academic medical centers to leverage their services, and extend your ability to treat more patients. The concept being that everybody wins in that scenario. Your patients stay, they continue, their family members are there, they're still spending money in the local economy. What are some key considerations when you're starting a telemedicine program? What are some practice models, workflows, telemedicine business models that make sense? I think we'll answer some questions now.
Okay, thank you, Morgan. So while we go through some questions, quickly, I just want to remind you to enter, if you haven't already, enter the questions into that box on the right-hand side on the control panel. And while we go through the questions, I'll leave this slide up just so you can jot down each of the presenters' contact information or email address in case you have additional questions that are not addressed during the Q&A session. Just give me a minute to pull up some questions here. Okay. So we have actually an interesting question, and I'll just kind of go down the line and see who it's appropriate for. I think this would be for you, Morgan. The question is concerning marketing. How do you ensure that consumers aren't coming into the rural hospital asking for a specialist telemedicine consultation, disrupting the provider-patient relationship?
Okay, so if I think I understand that question is that you have a provider-patient relationship already established at the rural or the local site, and now grandma's heard that there's a specialist that she can get access to via telemedicine, and she wants to get that access. If I understand that correctly, you don't want to advertise and disrupt the local relationship, but you want to market the telemedicine program, and you have someone asking for this service. I think it goes back to the communication piece, because if it's a specialist that she's asking for, I would assume that there's not local access to that specialist. So you have the local provider who she already has the relationship with host the visit. So then kind of everyone wins. There's better communication with the medical home or that already established relationship, because the specialist is not going to really do anything more than that special consultation. They're going to refer that patient back to the local provider for everything else. It would only be, in a situation where she would have to go to that large facility for inpatient care for some reason to receive that specialist care that they would affect the medical home, if that makes sense. Most specialists have enough patients in that sense.
Okay, thank you. Okay, this one's also for you, Morgan. Does Children's Mercy support hospitals or other facilities outside of the Mercy system? And if so, how do you determine what you will charge for a contract fee?
Oh, I love that question because I get to make fun of the fair market value. So we do have contracts with a lot of small non-Mercy pediatrician offices, family practice offices, rural clinics, behavioral health centers. The healthcare is funny in that we have to have, in order to stay within the regulations, we have to get a fair market value, which usually involves spending money on someone who is an expert. So contracting for expertise on fair market value assessments to tell us how much we can charge so we don't make too much money. So that's how we determine if that's the way we're going to go. Sometimes we'll go where we retain the right to bill the provider fee and the local site bills the facility fee, and then there is no invoice involved. I prefer that method myself because I think it's better for everyone involved.
Okay. So do you feel the repeal of net neutrality will negatively impact rural telehealth programs from either starting or striving to stay alive, or is it too soon to tell?
I don't want to hog all the questions. Ron, I have an opinion, but I'd love to hear what you have to say.
No, you can go ahead. Go ahead and start. That's fine. Go ahead.
Someone laid an article on my desk just yesterday about net neutrality and doom and gloom. Personally, I think it's all going to shake out just fine. The demand for telemedicine is already well established. Yes, it could have some impact, but I think our technologies are developing at such a rapid pace in this particular time in history that it's all going to shake out okay. But I'm an optimist. I'm also kind of a realist too, but I'm not sure that really answered the question. I'm not worried about it.
Okay.
Yeah, go ahead. That's fine, Carrie. That answers it. Go ahead.
Okay. Sorry, this is for you again, Morgan. Could you please review a typical workflow for a specialist visit from the rural perspective?
Sure. So that would be a scheduled visit. Those are also easier and less expensive for the rural site because in that scenario, you're just paying either for the provider's time, not for them to be on call, or you're billing your facility fee and the provider's billing their provider fee. So you would have someone there with the patient. So someone that checks the patient in or meets and greets the patient and then takes them to that private, well-lit space with great internet connection. And depending on the type of specialty, if it's psychiatry or a psychologist, you might not need ancillary exam devices, but if it's rheumatology or cardiology, then you're going to need digital exam devices available so that facilitator, that nurse, respiratory therapist, other trained healthcare person can be kind of the hands, if you will, of the provider to do that full exam. There's a video screen and the specialist is on the screen. They do their interview, the physical exam's completed. A lot of times they'll document at the same time. And then you as the patient site, access site, would receive a copy either through that secure electronic file transfer or an HIE. You would somehow receive a copy of the specialty visit, so that to go to the primary care provider to maintain that medical home, if you will. And then if there's a need for a follow-up, it would be scheduled, again, for however long out, and you just redo the same thing. The specialists e-prescribe, or I guess there's also a possibility that a small, I'm thinking about, like I said, where I grew up, a pharmacy that might not have the ability to take an electronic prescription. There might be a place like that still. So they would call it in.
Okay. Ron, this one's for you. ROI is driven by reimbursement. Can you provide a brief overview of the reimbursement status of telemedicine?
No, that's a great question. So I'll keep this brief. Of course, this could be a whole session in itself. So if you look at the current telehealth reimbursement status in the U.S., right now there are 36 states that actually have, about 36 states that have legislative mandates. So of course, we have three payers for the most part. We have Medicare, we have state Medicaid, and we have the private. So as we speak today, Medicare does reimburse for telemedicine, but they have certain criteria. And the criteria is the patient has to be physically located in a non-metropolitan statistical area during the time of the consult. They have to be, or in a HIPSA, health provider shortage area. It does have to be a live video interaction, so a live session between the provider and the patient has to be physically located, like in a hospital, federally qualified health center, physician's offices, rural health clinics, skilled nursing facility, outpatient mental health facility, inpatient dialysis center. I'm doing this off the top of my head, so if I miss something, I apologize. But those are the main ones. But they have to be in a facility, and they have to be in kind of in a rural area. We have seen some, and then there's specific providers, right? A physician, nurse practitioner, mid-level, LCSW, psychologist, and the list goes on. We have some exciting things within the last week. If you look at something like some of the new regulations that have come out through the Chronic Care Act, which is FAST, which is further in access to stroke, as we talk about that being such a key application through Medicare, is starting in 2019, where they're eliminating the geographic restriction where a stroke patient can be in an urban area, in a facility within an urban area, and receive that. And they're also expanding the ability and flexibility for accountable care organizations. Now, when we get to the Medicaid and state level, as I said, there are 36 states, around 36 states that have legislative mandates. Now, what does that mean? If you think about, each state makes their own decision, right, on how they're going to reimburse for Medicaid or not. There are two ways they can do that. You can either do the legislative route, which is where you go to one of your legislators and you say, hey, we want to pass a law, and a lot of times they'll pass basically a parity law. And what a parity law is, what I talked about, a parity law is basically they say that you have to provide the same reimbursement as you would as if someone was seen in person. Now, what I recommend though is Medicare regs are very simple. That's just one reg, right? Because it's a federal program. But when you look at your parity laws or your Medicaid, make sure that you look at your own state Medicaid reimbursement, because parity can mean that they have to reimburse, but is it reimbursement parity? So look at the specifics. That's important. Okay. The other way that organizations can basically get reimbursed or Medicaid is you basically go in and you just get a legislative, not a legislative, but it's basically through policy. They make it a policy. We did that in Maine many years ago before they did a legislative mandate. Now the privates, if the privates are in one of those 36 states that have legislative mandates, then they have to reimburse, right? But the great thing is that out of all of the states, even if they don't have legislative mandates for Medicaid and for privates, all but one basically that I know of, and these things change as you can imagine because there's all the different states, they do reimburse for telehealth, and there are specifics. So it's very proactive, it's been very open, and I think a lot of folks would say reimbursement is the issue. I think our experience doing this a lot in the US is reimbursement isn't the issue as much as people make it out to be, but there are some of those situations you just have to understand and be careful. And we're more than happy to provide you or provide or have discussions with you so you can better understand that for your organization as you move forward. So long answer, Carrie, but that's it.
Thank you.
Yeah.
Okay, this could be Morgan or Ron, I think. Could you kindly share the pros and cons of building telemedicine from within the organization versus leasing from established platforms and branding under your own organization's name?
This is Ron. Can you repeat the question again? That was a little bit tricky. Go ahead.
Sure. Could you please kindly share the pros and cons of building telemedicine from within the organization versus leasing from established platforms and branding under your organization name?
Okay, so basically I think the question is, do you have your own providers? Do you have your own providers with your brand providing the clinical services, or do you use outside resources and services to provide services to your organization? At least that's the way I understand the question.
Yep.
Morgan, do you want to take a crack at that, or?
Yeah, I can. I think they could also be asking about the technologies, but I think we can answer it either way. So
sure, I'll take the technology if you want. You can take them.
I think that's good. Yeah, good idea. So I think it really depends on the resources you have at your organization. If you have, if it's, and Ron will speak more to this, but if you have great information systems and IT people and you think you can put together a solution and you have enough providers to support your offering, that can be, there's some disadvantages, I think, if you're going to want to go to scale at any time to that approach. But as more and more of these direct-to-consumer providers, companies pop up, their prices for their platforms and stuff are going to come down. So I think that if you can wait just a little bit, contracting for those services is going to get more reasonable, mainly for the technology piece. And then you can determine who serves on the platform, and it could be a combination of both your own providers and the providers of that company that you have contracted with. You just don't want to overwork. I just really feel strongly that you don't want to ask too much of your providers. Your program will be more successful if you take people that are champions and interested in this from the beginning, and then let the mid adopters, the later adopters come along on their own time.
Yeah, this is Ron. No, I think you're, there's not really much to add there. I think it's really two things: is look at your internal resources, look at the scale of what you're trying to accomplish, and I think the first thing is, like any other program, I sometimes when people develop telemedicine, I've done consulting for different organizations in the U.S. and overseas, and I think the first thing is an organization really has to align telehealth with their organizational goals, because what will happen is if you don't do that, and I'll get back to the question, is if you don't do that, you'll just have a couple doctors that think technology is kind of cool and they want to do something, and you'll hear this great program, and then those two doctors or one of those doctors move away and the program crashes, right? That's not really integrating telehealth into the fabric. So as far as using what technology you use, and outside, I'll take it from a technology perspective, it's really about scale and volume, and whatever the application is. Some technologies are very easy to use internally and you can manage them. They're very low maintenance, but it depends on the specialty. Like I said earlier, if it's stroke, then you need something that you make sure is up. If it's more outpatient services, you want to make sure it's up, but it's not as critical if it's in a clinical situation. So I think you just have to look at, not a straight answer, but you just have to look at each clinical situation and the volume and the intent, and you can go from there.
I completely agree. I just wanted to say that it's important, and I meant to mention this, but I don't think I did, that you do have that vision and mission of your telemedicine program aligned with your organization's vision and mission, because you will get plenty of people with their bright ideas, and they are often bright, truly great ideas, but you have to focus your efforts in the beginning, and then you can do some of that fun stuff later, but you got to have some wins and be well aligned early on.
Great.
Okay, great. I know it's after 3:30, but we still looks like we have people logged on. So if you guys are both open, there's some more questions would like to go over.
I'm fine.
Yeah, I'm good.
Okay. So a couple more. How would a rural site handle multiple distant sites? It seems difficult to find one larger facility that we would transfer to as needed that has the scope of telemedicine services.
Can you say that again, Carrie?
Yeah, sure. The question is, how would a rural site handle multiple distant sites? And their comment was, it seems difficult to find one larger facility that we would transfer to as needed that has the scope of telemedicine services.
You know, I think that could be like a double model, if I understand the question right. So if you're already a rural site, but you are fairly good size and you have relationships with even more rural providers, then what happens when you really need to transfer a patient or you need additional expertise beyond your level? So that would be like a hub and some spokes, and then the hub becomes a spoke to an even bigger facility. And I think it is hard for those places to find medical centers to partner with. I think one of the benefits, hopefully, of this webinar, if you're in that situation, is if you put together your portfolio and answer all those questions that we went over, then you could start approaching, larger places and see if they would be willing to, partner with you if they already have an existing telemedicine program. You might want to align yourself with a state, with a city that's close, that at least borders your state, because they're going to have to get a license. If they're not already licensed as providers in the state where you're located, they will have to get medical licenses in the state where the rural access sites are. Did that make sense?
Oh, it does, and I think that's a good question, but that's a common issue and a common theme, right? Morgan and their organization, they've done a good job. They provide a lot of specialty services, but sometimes it can start out and it can be it'll be sort of specialty specific to a certain department, and then it'll basically build up and roll out from there.
Okay, this next question: in partnering with a hospital or other healthcare providers, how do I set fee percentages?
I think that is a question about billing, and I'm not familiar with that term. We either, like I said, reassign our billing rights to the partner, and then we invoice them, or they bill facility fees and we bill provider fees. So
a question on that, Morgan, though, is when you look at fair market value, the term that you brought up, is there any formulas? I mean, if you look at I guess what I'm trying to get at is, because we get this question a lot, and I think what folks are asking is when you look at that number, let's say they're going to contract with you or a larger hospital and they're going to buy like 2 hours of a clinician's time, right? And then they do the billing, so they try to recoup the money on their side. So they do the billing and you invoice them every month for the hourly. When you look at fair market value, do you just look at the number of patients that are seen per, you would just average out the number of patients that would be seen per hour, or is there any known formulas that you're aware of that organizations are using to come up with some of these numbers? Because I know this is something folks struggle with quite often. Does that make sense?
It sure does. And I wish I had the answer, but I don't, because we outsource all of that. You know, I ask Google for everything that I don't understand. So, and you may not be able to find some resources because those third-party companies may protect their little equations for that. So I'm not going to be a good resource. But if that is something that you also, whoever asked the question, is really struggling finding some resources, I'm happy to certainly dig further into that. Just email me directly and we can
and we work. Oh, I'm sorry, Morgan. And we work with some organizations, as you could imagine, that are working underneath that model that I just brought up. And I'd be more than happy to make some introductions to some organizations that are doing that for you as well. And we could help you out with that. But as far as their exact formula and how they come up with that number, I don't know. I will, in a basic way, I know they'll look at the average number of patients per hour that they would see. They would look at their normal rates, and then they would just put a certain percentage on top of that to cover the infrastructure and the telemedicine time. But that's basically it.
Okay, I think we've addressed most of the questions. There's a few left here that we can try to follow up with outside as well. Just wanted to say thank you to Morgan and to Ron for participating in the webinar and giving us your thoughts. And thank you to the attendees for listening, and we will send a follow-up email with the link to this webinar recording, as well as a link to a copy of the slides. Thank you again, and have a good day.
Thank you.
Thank you, everyone.